Okay, so this is a quick overview, okay? I'm going to talk about mostly the first part. And the reason we do coronary CTA, I think, obviously, is as a cardiology, we're not doing a good job in predicting presence of disease when you send a patient for coronary angiogram. And this study probably a lot of people are aware of. I think less than half of patients you send to the cath lab have actual disease, okay? So, and the reason being, we want to replace invasive angiogram. It's obvious. It's costly. There's a certain risk. And coronary CTA for the last decade has established to be the non-invasive method of choice to exclude the presence of coronary disease. Okay, the data I'm not going to show you here is overwhelming. If you have a reasonable quality coronary CTA and you don't see any obstructive disease, 99% of the time there is no significant stenosis. Okay, so it's perfect methodology to be the gatekeeper for coronary angiogram in patient that you want to establish presence or absence of disease. So this is the most common indication. You want to detect the presence of coronary disease. Symptomatic patient with chest pain, ischemia equivalent with shorter breath, for instance, but they have low to intermediate pretest likelihood of disease. If someone come in with high pretest likelihood, coronary CTA at this stage might not be the perfect preferred choice. Or if you have a patient who have ECG cannot be is uninterpretable or cannot undergo a stress test, coronary CTA will be the option. And in the workhorse of most of the CT is 64 slices. Done correctly, you can produce exquisite image like this. Okay, this is just a regular one of the probably older 64 slices, but if you prepare the patient adequately, you can have image like this. Typical example, I'll give you some examples of patient. This is a young patient who had atypical chest pain. The brother and father both had MI and sudden cardiac death in their early 30s. So, and he wants to know. He wants to know if you have obstructive disease. You offer the stress test to him. He say, no, I want to know if I have blockage or not. So this was done with a 64 slice CT. Again, pristine coronary. The guy has no plaque whatsoever. Okay. Versus this is a patient with hypertension and chest pain. You can see, the only risk factor is hypertension. He has a distal left main disease. That would be again, this is a patient who show up and he declined a stress test. And it's documented by the coronary angiogram. And this is another patient with 35 years old, continue chest pain, keep coming back with a chest pain, and I repeated, treadmill, nuclear, and even a stress echo, I believe. And having a single coronary. I'm not sure that's the cause of his chest pain, but it's an interesting finding and nice picture. Okay, so other indication is if you have a prior test result and it's equivocal. This is, again, I would think for insurance approved purposes, because you work in a hospital environment, so you order a test and pretty much most of the CT will get done, right? But when you go out and you practice in the office, you want to order a coronary CTA. I mean, insurance, they don't like it, okay, because it's expensive for them, supposedly. So, but this indication is basically, this is the buzzword, okay? If you tell them the patient has chest pain and has equivocal chest stress test or non-diagnosed stress test, they'll approve it right away. So this is, the first one is probably, I think, the most common scenario is not going to get approved, but this is very important, okay? If you have a exercise treadmills, perfusion, stress echo with equivocal, I mean, they'll approve this test. I apologize, I don't know why the video is not running. Let's see. Okay, for sake of time. So this is a patient who underwent a bike echo, had very subtle changes in the apex and basically CTA. An old day patient would have gone to the coronary angiogram, but nowadays with the coronary CTA, you can very comfortably tell the patient that changes is probably due to blood pressure changes during the stress test, or this patient with who underwent myocardial perfusion imaging with a anterior defect because she's 46 years old, not having risk factor, coming with acute chest pain to the ED. We don't think that the patient has coronary disease, and the defect could be because of the breast changes, position of the breast during stress and rest imaging. So CTA again proved that the patient does not have any significant disease, and the patient and the cause of chest pain is patient had a large hiatal hernia, and that's one of the additional benefit of CT. Okay, if you do a stress echo or nuclear, it's normal. Patients still have chest pain. Oftentimes, what do you tell the patient? With CT, so you can tell other non-cardiac cause of chest pain, and that's been shown to be up to 20% of the cases. You can give the patient a diagnosis, which is, you might not be able to do too much about it, but I think it's very important for the patient to know, and that has been shown to decrease the recurrence of the ED visit if you give them a diagnosis and some type of follow-up. One of the major indications for CTA, or at least the community has been pushing really hard, is imaging the patient, show them the ED with acute chest pain. Okay, and again, this is just an example of the patient with, I'm not projecting very well, has basically have a lot of risk factor, negative troponin. So she was enrolled in one of our ED study and got a CTA. Versus this patient, again, has a very high-risk plaque in LAD, basically non-calcific plaque, positive remodeling, little bit of calcification. So all those are high-risk, considered high-risk feature for plaque. And again, this is one of the major advantages of CT compared even the coronary angiogram. You'll be able to look at, the plaque characteristic, unless you couple IVIS or CT with your CAT, which is obviously is not done routinely. So, and with the better technology, I think the plaque characterization will become probably one of the major indication for follow up the patient with plaque with either pharmacological therapy or to treat this high risk plaque prophylactically. But so anyway. So plaque characterization is other added information you get from getting a good quality CT. This is just a CAT correlation. And this is a little bit some examples that I mentioned you to earlier. Hiatal hernia, pneumonias, PE, dissections, other causes of chest pain you can discover with coronary CTA. And this is the Dear to the Heart of Dr. Lin, okay, CT. For assessment of complex congenital disease, I think for anomalous coronary arteries, I think CT, because of, MRI could give you same information with no radiation, obviously, but I guess for the ease of the test, and I think CT is probably the first line of diagnostic testing. So to give you some examples. So this is a patient I saw when I was in Wisconsin. He ran track and field for the Big Ten University for UW, and one day during training he had a sudden cardiac death, was resuscitated. So essentially he has L kappa. So basically the left coronary artery is coming out from the PA, and MRI shows he did have necrosis or late hyperenhancement in the anterior wall. EF was in the 40s, and he was lucky he underwent surgery and did very well. And this is another case that we saw, a patient with abnormal stress echo. As you can see, she had one single coronary, only the right RCA. And as you can see in the 3D rendering here, what the sequence was, she had this abnormal stress echo, underwent cath, and they couldn't find the left coronary artery, so they suspected a coronary anomaly. So CT was done. But again, they weren't too sure about this echo because the changes was very minimal, only the apex. So we repeated. So you have congenital conditions who may not or may explain the symptom. So that's only anatomical information. So the functional information was provided by SPEC. You can see there, she did have a little bit reversible perfusion defect with exercise in the apical anterior wall. If you look at the 3D rendering of the CT carefully, I can't make it. Do I have a pointer here? Okay.
You can move the mouse to point.
Oh, okay. So if you see, the whole entire circulation is hinged on this right coronary, and you can see this distal apex right here has very little vessel. So it's a possible condition that, this obviously this area is viable, but it's probably not received enough coronary circulation during stress. So as a matter of fact, the patient, there's nothing we could have done, and there's no therapy. And I think 1 month later, patient come back with sudden cardiac death and requiring a defibrillator. So some of these single coronary might not be as benign as we thought originally. What's your thought? Do you think it's plausible?
I have no idea what to do.
I know. I mean, it's one of those few cases that we actually seen the single coronary with function. Most of the time, the stress tests are normal, and made you wonder if, obviously, all these patients need to be anti-ischemic therapy. Okay, so this is a congenital case. The patient has, who has done CT? There's some audience participating. Raise a hand. No, nobody has done CT. Second year fellow has done MRI. No. No. Volunteer. Come on. No volunteer? I need to pick on a Methodist fellow. Okay, Omar. What do you see in the left-hand side? I'll give you a hint, okay? So this is ascending aorta, all right, in the sagittal view. This is arch, and very good coarctation. Okay, when you see a patient with coarctation, what are the congenital anomalies associated? Yes, it has a bicuspid valve, and so this is almost like a four-chamber view of the heart: left ventricle, left atrium, and right atrium. Also has what? This is the interatrial septum, so it's an AST. So, okay. And this is one of the things that I think Dr. Lin, we're seeing more and more, patient with unexplained enlargement of the RV and RA. And this happens to refer to us for AFib ablation because I guess atriums are huge and turn out to have anomalous partial anomalous pulmonary vein return, okay, so, which is obviously very hard to diagnose by echo, even by TE, and we're seeing more and more actually in cases like this. All right, Omar, you want to give a shot in this one? 36-year-old with a long-standing history of murmur. So this is ascending aorta, descending aorta, so it's a cross-section. And this is PA. Basically, they're giving away the diagnosis. PDA, okay. See, you usually see in the echo just a little color flow going through. Actually, you're seeing it right now, okay? So, okay, so that's indication I think is very useful, but not used enough, I think, for assessment of a patient with new onset heart failure for if it's ischemic, non-ischemic. For now, we usually do a stress test. MRI is very good in determining ischemic and non-ischemic, but as most of the cardiology, you want to know the coronary anatomy, okay? So just some examples, 37-year-old female with chest pain and shoulder breath with very dramatic ECG changes, EF in the 20s, CTA completely normal, and it's turned out to be a stress-induced cardiomyopathy. And this is another patient with, again, similar presentations. And this is the last case, my personal patient with diabetes, family history MI, has AVR, huge heart, had wall motion abnormality, and CTA shows basically no significant disease. The surgeon doesn't believe it, so he will send the patient to cath. You got to take my word for it. There's no significant coronary disease. Okay, this is those rundown on most of the major indication to use coronary CTA.